Good afternoon, everyone. My name is Lisa Knowlton. I'm an assistant professor of surgery at Stanford University Medical Center, and I'm here with Ryan.
Hi, good afternoon, everybody. Thanks for joining us. My name is Ryan Dumas. I'm an assistant professor of surgery at HEC Southwestern and at Parkland Memorial Hospital.
So we're very excited to present today's AAST Virtual Grand Rounds, which is actually a collaboration between the AAST Associate Membership, the Healthcare Economics Committee, as well as the Military Liaison Committee. So just for housekeeping purposes, we'll ask that in order to keep this session on time, if everyone could put their questions in the chat box, and then we'll plan to leave time for Q&A at the end. But we definitely want this to be an interactive session, so welcome your questions.
So with that, I just want to introduce our topic. And really, when we thought about this webinar, we wanted to pick something that was relevant to the entire membership and really what's our current and really ever important theme in our practice. And that's really transitions in practice. So ranging from your first job to maybe a mid-career change to leadership opportunities, and also scaling back towards the end of your career. So with that, I want to introduce our first speaker, Dr. Fitzgerald. She's actually a recent graduate from HEC Southwestern, and she just completed her ACS fellowship with us here at Parkland. And she has just recently joined the team at ECU as an assistant professor of surgery. And she's going to kick us off by talking to us about finding the right fit.
Thanks, Dr. Dumas, and thank you to the AAST and the associate membership for giving me the opportunity to share a little bit of my story today. As Dr. Dumas mentioned, I'm Fitzgerald. A little bit of background about me. I'm actually from New Jersey, but did most of my schooling in Atlanta, Georgia at Emory, where I did my undergraduate med school and then did 7 years of residency there. And then just finished up my 2-year trauma ACS fellowship in Dallas. And now I'm heading on to ECU for my first faculty position that I start in a couple of weeks. So my part of this webinar is talking about how I found the right fit for my first job. And so the way that I wanted to structure my part of the talk was kind of looking at the top 5 things that I learned when looking for my first job. So I think the first lesson that I learned is kind of know before you go. And what do I mean by that is kind of doing some prep work before you even start the process. I think the first thing you have to ask yourself, or at least kind of what I asked myself, was what type of job do you want? I think we know the trauma ACS critical care world is pretty broad, and there's a million different ways to have a trauma acute care job. So I think the first question to figure out for yourself is, do you want to stay in a community style practice, have academic practice, or do you want to have a hybrid where you maybe don't want to be at a full academic center, but you want some exposure and so want to continue on teaching? So I think that was the first big question that I answered, and I knew that I wanted to stay at a high-powered, high-volume level in academic centers. So that made kind of the initial search a lot more simple, as I could weed out a lot of programs that were not offering that. The second thing I think you need to think about, and it's super important, is what are your non-negotiables? And obviously these vary per individual. Are you someone who wants to be or has to be in a specific area of the country for family reasons or for personal reasons? Are you someone who is a basic scientist who may need access to a lab space or basic science resources, which may be a little bit more complicated to negotiate or figure out what's available to you than maybe a clinical research style practice? Or are you someone that really loves elective general surgery and wants to continue in elective practice? Or on the flip side, a little bit of a polarizing topic, are you someone who hates elective general surgery and do not want any part of having that type of practice? So what are your non-negotiables, things that you really don't want to change on throughout the job interview process? The next thing, and I kind of say this a little tongue-in-cheek, is to design your unicorn practice. And by unicorn, I mean, what is your absolute no-holds-bar ideal practice for you? If you could have everything you wanted, carte blanche without any limitations. And I think it's, at least for me, it was really important to kind of define what I wanted to do and how I wanted to build my practice. So then I can go into the interviews and figure out what place is going to give me at least the majority of this unicorn practice that I wanted for myself. I think, you have to ask yourself, are you someone who prefers one of the 3 pillars of ACS more than another? Are you someone who loves the ICU? Are you someone who hates the ICU, love trauma, hate trauma, etc.? Again, as I mentioned, do you love elective general surgery? Are you a robotics fan? Do you have a niche practice that you kind of developed throughout residency or fellowship that you want to continue and bring that with you into your job? And then again, don't be afraid to define this on the interview trail. I think it's super important for the places that you are looking at to know what you want so they can be able to make sure that they can provide, again, the majority of it to you, because it'd be silly or a shame to go somewhere where you can't do half of what you thought you could do or wanted to do. And then have your elevator speech down. I think pretty much every interview, multiple times I was asked kind of, what is your ideal practice? What are you looking for in your first job? So really have that kind of 2 to 3 minute answer, really nailed down, able to kind of, say on the fly. Because again, it's definitely a question that was asked pretty much on every interview or every person that I spoke with on the interview trail. The second lesson I learned is really ask the hard questions. This is the time to really kind of delve into each program to see what they're offering you. Because this is, again, a little bit different than a fellowship or residency interview, where I felt like in fellowship and residency, I was selling myself a lot more than the programs were necessarily selling themselves to me. And while I was still selling myself and trying to, make myself the best candidate possible on the job trail, I felt like the programs were really trying to sell themselves to me a lot more and to make sure that what I wanted was what they could offer. So really make sure that you're asking the hard questions. Some of the questions that I thought were important or became important as the process continued was, what is a 1.0 FTE mean at each institution? It does vary. Some places did it based on number of call shifts. Others were based on service weeks. Some institutions, 24-hour calls counted more versus 12. So really just get to the nitty gritty of what an FTE means there. Asking about the pay structure, a little bit of a taboo topic. I felt like most institutions were pretty forthcoming with your salary being somewhere within the 50th percentile for the AAMC. And I think there's a way that you can ask the hard questions about pay structure without getting into the hard numbers on the interview trail. Things like, are you RVU driven at all? Do you have a bonus structure set up? Just again, give you a sense of what you're getting into kind of when you get there. I think it's important to note if there's a lot of turnover in the department, especially with the chair or the division chief or the trauma medical director, and tactfully try to ask why that happens. Are people just getting promoted, which is great, and leaving the institution to get, to move up the ladder? Or is there a deeper underlying issue that may not be as apparent on the surface? Other questions to ask is, where did the faculty train? Are they all from the same institution, bringing kind of the same ideas, or is everyone trained at different places? I usually ask what a typical month in the life was like for each faculty, just to give myself a sense of how much service time is required there. What are the service weeks look like? What is their call schedule? Again, just to give myself an idea of what I was getting into. One question that I found to be super important was asking about satellite campuses and how much time is expected for you to participate at those campuses. I knew that I wanted to be at the main campus for most of my first couple of years at least. So again, an important question. Asking about research and grant support, and then finally resident and fellow culture, just to again know what kind of environment you're getting into. Third, resources. I think faculty and residents at your current institution or at an institution where you did your residency are honestly some of your best resources. I reached out to everyone I knew throughout the process to ask about the inside scoop at all these locations. I think, the trauma world is a pretty small world, and I knew someone that I knew everyone at places I was interviewing. So it was really helpful just to, again, get some of the background about the job that you're looking at. And don't be afraid to reach out and ask those questions. The fourth lesson I learned was really don't ignore the warm fuzzies. And again, a little tongue in cheek, but I think it's really important to note that you should fit in where you sign your contract. You should really feel that that institution is interested in you and wants to take you on as a first year faculty and really kind of help grow your career. As I mentioned earlier in the talk, you should be able to do the majority of your unicorn job where you sign your contract. Again, you don't want to give up on your non-negotiables, and you don't want to give up on too many of the things that you want to do, because then a year or two in, I think you'll be pretty sad kind of with how your career looks. And then when you're on your interviews, and probably a little bit more so when you're there in person, really watch how the faculty interacts with each other, with the staff, with the residents, with their partners. If you go out to dinner with them and they bring their families along, just really kind of see how they interact with each other, because again, you're going to be in that group as well. And then a couple of last questions that I thought were important to ask yourself is, do you feel like you and your personality fit in? Do you feel like these are people that you can call for a silly question? I think we all know that if you had a horrible trauma, a retrohepatic cable injury, or some kind of rare trauma injury, people would be running into the OR to help you. But what about in those cases where it's a routine case and something that just doesn't feel right? Do you feel like you have partners you could call in to just take a quick look and not, feel silly for asking that question? And then finally, do you feel like you'll be able to grow your career where you end up, which again, I think is super important, academic side of things. And then finally, something that was hard for me to learn was that everything in a contract is negotiable. And I didn't originally think this. So read through everything in your contract very carefully. I had a friend who was a lawyer look through my contract just to make sure that the legal jargon that I didn't understand wasn't, confusing, or it all made sense to me. Send a rebuttal letter with points of negotiation, whether that's salary, your starting date, if you need specific resources for research, and anticipate that you'll meet somewhere in the middle. And again, this was hard for me to do because I'm not a person that likes to send rebuttal letters and negotiate, but really just reach out and send a letter and see, you'll meet somewhere in the middle. And then remember, a thing that I was told a couple of times as I was signing my contract is your starting salary will be the salary that your raises will be based on eventually. So really make sure that you're trying to negotiate for the best salary that you can. And I think that was all I had to say. I think we're going to do questions at the end of the talk. Again, thank you for this opportunity. Here's my contact information. If there are any questions offline, I'm happy to answer them going forward.
Thank you so much, Caitlin. Dr. Fitzgerald, that was really great. And yeah, please, for the junior faculty online too, Caitlin is a tremendous resource. Sometimes the best resources are those people that have just gone through the entire process. So please, like she said, please use the chat liberally to ask questions, and certainly don't hesitate to reach out. So we touched on how to get your first job, and so let's transition to how to get your second job. Or a new job, right? So what about transitioning to a different opportunity and how that looks? So with that, I want to introduce Dr. Michael Cripps. Dr. Cripps is a professor in surgery at the University of Colorado. He's the section chief of trauma and acute care surgery. He's a trauma medical director at the Anschutz Medical Campus. And most importantly, he's a close mentor and a good colleague and a great friend. So with that, Mike, take it away.
Excellent, thanks. Are y'all seeing the full screen?
Yes, sir.
Perfect.
No, sorry, Mike. Actually, we're seeing your notes screen.
All
Yeah,
right.
you're in presenter mode.
Yeah.
Switch your display settings.
Yeah.
By now.
Yep, that looks better.
Perfect. Excellent, thanks. Well, I'd like to thank the WST and the WST Associate membership for allowing me to talk about something that I don't think is really discussed enough at the national meetings, and that is how to switch jobs and start again. For disclosures, my consultant work won't affect today's talk. I am going to go pretty rapid and really just scratch the surface on this. This could be an entire seminar. Throughout the talk, I'm gonna list some books that I thought were helpful when I was changing jobs. They're by no means an endorsement, but things I thought were helpful. There are a lot out there. So who is this talk for? So typically this talk is for the late assistant professor, the early associate professor, someone who's been in the job about 5 to 6 years, although it can be anyone. And typically this person's going along, enjoying their job. Everything's going great. The career is moving along, and generally they're feeling fulfilled. And then something happens. And this something could be a lot of different things, but it's a change, and it's change that's coming. It's something could happen suddenly. It can be something that was very slow growing, be something that you were trying to ignore for a while, but for whatever reason, it's no longer something that you can ignore, and you think it's a change that's going to affect your career. Now, what are these somethings? Now, there's a whole range of these, and I think the range is based on the emotional response to this something. So one of it, on the happy end, you can, Dr. Davis can call you from Yale and say, hey, I want to bring you in to lead one of my sections here. So you get offered promotion at this world famous institution. Still in this happiness category, you see a posting for a job at your dream institution and you apply for it, and they offer you an interview. Moving on down this scale, you could be going along and you're pretty happy, although you're starting to get this feeling that you're really outgrowing the resources that your institution has to offer you, or you're sitting at home and your spouse comes home and says, hey, they've been offered a job at their dream institution and it's in another town and you may need to move. And then moving on down towards the other end of the spectrum, you feel like your institution is moving in a different direction than it was when you first started, or perhaps there's new leadership and you don't feel that they're as supportive as the old leadership was. And then, of course, at the very end of the other spectrum, a direct conflict with leadership or with your clinical partners. Now, on the same end, on the unhappy spectrum, I will say that there's this other category of catastrophic implosions that it can occur. I'm not really going to address that today. If you want to reach out to me and ask me my opinions on that, I'm happy to discuss it. When I do get to the part of the talk where what to do when you land at your new job, absolutely, this would apply for people who went through a catastrophic implosion. So one of the things to consider when these somethings happen is to be aware that whatever emotional response you're having is normal, whether it's happy, ecstatic, or very angry and upset, it's normal. And these emotions should be a part of your decision-making algorithm, but they really shouldn't be the sole decision. I mean, hey, you got this offer from Dr. Davis, you're super excited. Don't quit and just ask her when your start date is, all right? You get super upset at your leadership there. Don't quit and go start looking for a new job. Because your goal here is to take a very pragmatic approach to end up in a better situation than you are currently in. For the entire spectrum of these somethings, from the good all the way to the bad, the first thing to do is check in with yourself and ask yourself some very introspective questions. What is it that you're wanting? What is it that fulfills your mission? And who do you want to be? When you look back at the end of the career, what will make you happy that you had this career? So starting down these emotional responses on the happy, and what is it there to worry about this category? It's your dream job, right? Well, I will tell you that there is no such thing out there as a job without financial constraints, politics, clinical stress points, etc. And when you're being recruited, they're not necessarily going to put these out there in front of you for you to see. They're trying to put on their best face, okay? So be excited about this job. Be very excited, but be thorough in your investigation to what Dr. Fitzgerald just got through saying for the first job. You have to ask the questions, and you have to have these questions answered about yourself first before you know what questions you want to ask of the employer. Talk to the people that have these jobs elsewhere. See what advice they have for it. Because remember, your goal is to end up in a better position than you are currently in. Because when you think about this dream job, moving can be a very, very real stressor, not just for you, but for your family and your friends too. There are going to be components of the new job that do not, there are going to be components of your old job that do not exist at the new job. And these are things you're going to miss. Now, it's not to say that there's not going to be more and different kinds of new enjoyable experiences, but there are going to be things that you miss at the old job. And I'm not trying to inhibit anybody's decision-making or prohibit them from making this job, but these things need to play in the decision-making algorithm, because you don't necessarily want to trade with this huge amount of expense and huge amount of effort if there's only minimal improvements. Instead, what you can do is use these same strategies to negotiate with your own institution to provide you with those things that you think are missing. This is what we call a retention package, so that you can actually end up with that better job at the same institution that you're already at. Now, don't overuse this, because then you can run the risk of becoming what's seen as a malcontent, somebody that's never happy. They're always asking for something every year, every budget cycle. So don't do that. Use this sparingly, but you can use it to help get you, you can stay in the same spot and have your dream job. Now, what about on the other end of the spectrum? Now, these emotionally can be much more problematic. Not only does this stress cause at work, it can bleed over into your personal life as well. But the first steps remain the same. Take a step back. Ask, what is it that you're wanting? What fulfills your mission? And what do you want to be? Because a lot of these things that are causing discomfort are due to a change. And it's important to remember that change isn't any more bad than staying the same is any good. So when you ask yourself these questions, ask, what is it about the change that's causing you so much stress or friction or anxiety? Lots of times these changes that occur will provide you weeks, months, maybe even years to ask yourself these questions and to self-evaluate. But self-evaluate can be very difficult. And so there are a ton of resources out there, lots of books, courses that are available, other people that have gone through this that can help you evaluate yourself and to give you some direction on how to do that. Also, on this sort of time frame, on this sort of issue, I also suggest a 360-degree eval. Now, anyone that's ever gone through a 360 eval will tell you it's not the most pleasant of scenarios. They are done to help you identify blind spots about yourself. And if you're already going through a stressful time at work, this can seem like adding more insult to injury, but it's not. It's there to help you identify those areas that you can improve on yourself. And this is an area that I unfortunately see several times that people skip over this step. And you can see it when people go from job to job to job, trying to find a place that's going to make them happy, that fits their criteria, instead of looking at themselves, seeing what they can do with themselves to fit in better to the institution. Because the only thing you can really truly control in this scenario is yourself. It's your own ego. So when you're asking yourself these questions and you're reading these books and you're going through these courses, ask yourself, can you do things that can pivot yourself to get back into position and alignment with the institution or with your leadership or with your team? What can you do to manage up the chain of command to put yourself back in alignment with the institution and leadership? Because if you do this, sometimes you can actually take this unhappy, frustrated scenario and put yourself in the happy scenario. And then in doing so, develop your own retention package. Sometimes that's not possible. So if that doesn't work and you are certain that you have done every single thing you can to mitigate your own contribution to this friction scenario, then it's time to cultivate your exit strategy. During this exit strategy, don't be mean, don't be resentful. Do your job to the absolute best of your ability in the circumstances you have. And then you actually proceed with the same plans as if you saw a posting for your dream job and you applied and you got an interview. Because again, your goal is to end up in a better position. So why not make this your dream job? And I know it's cliche, but it is true. You don't want to run away from a job in as much as you want to run to a job. When you land at your new home, listen, be curious about the new culture that is there. Whether you're in a leadership position or a rank and file surgeon, you are now implementing change into that system. So now you are the change. And you're not any more bad for being the change than the old way of staying the same was any good. If you are taking up a leadership role and you left because of change, take that to heart and remember what it's like for your new team to be going through this change with new leadership. The new team is going to be very, very excited about your arrival. They're going to be excited to hear your new perspectives, your ideas on how to approach problems. But it's important to also remember that some of the strategies from your old institution may not work at the new one. And if you are directly asked how you did something at your old institution, then please say so. But avoid this constant daily, well, at so-and-so, wherever it was you were before, we did it this way. That doesn't go over very well after a time. There are going to be new challenges at the new institution that you're at, but these challenges will make you better. Remember, they picked you to come be a part of that new team, and you can take all the lessons you've gone through this something that occurred, and you can use them to your advantage. So in conclusion, some things come up all the time, everywhere across the nation. The only thing you can control in these situations is yourself. So spend some real time discovering who you are, who it is you want to be, and what it is that you want. Manage yourself. Cultivate your exit or your retention strategy so you can land up in a better position than you were. And I'll be happy to entertain questions here, or if you want to message me afterwards, I'd be happy to talk. Thanks.
Thank you so much, Dr. Cripps. I think that talk had very meaningful applications for people throughout their careers in acute care surgery, and definitely very insightful to do a lot of self-assessment in the process. Our next speaker is Colonel Jennifer Gurney. She's also chief of the Joint Trauma System, and she'll be speaking to us about transitions into leadership roles.
Thanks, Lisa, and thanks, Ryan. Can you guys hear me okay?
Yes.
All right, great. So thank you so much for the opportunity to speak. Actually, when listening to Caitlin and Mike, those were great talks. You guys could have obviously given this talk on when to transition to leadership roles. And I got to say that when Lisa and Ryan asked me to do this, and by the way, I am in the military. I just took my uniform off because I was so uncomfortable because I was in the dress uniform all day because I was speaking at a meeting. But I have no disclosures. These are all my opinions and just mine. But when Lisa and Ryan asked me to give this talk, I thought, is this because I'm old? Like, what are they talking about? Like, this must be a senior thing because there's no way that people see me as a leader. Like, that was my kind of first thought. So I, had to kind of dig into this a little bit because I am a colonel in the Army. And, when you're a colonel in the Army, you're considered a leader, whether or not you deserve to be one, you're considered a leader. So I looked up some stuff and said, okay, I looked at what some of the definitions to lead. So leading, causing a person or animal to go with one by holding them, like on a leash, that's really not how you want to lead, right? And then a position of advantage, coming in first place, leading, that's not how you want to lead. But I think, an example for others to follow. And if I was thinking, the most important thing about leadership that I've learned is it's not really position, it's not really power, it's influence. I think leadership is about, having influence. There's differences between the military and civilian. I looked at some of the participants, and there's some military people on here, and there really are some challenges I think that we see in the military. So we rise through the rank. So you're considered a leader once you're a major or lieutenant colonel. That doesn't mean that you are. It just means that you've been in long enough. And so because of that, there's this principle called the Peter principle, and this, Mike talked about Michael talked about some books to read, and those were great books. The First 90 Days, love it. The Obstacle is Away. I think that's an incredible book. There's also this book, The Peter Principle, written by Lawrence J. Peter in 1969, and it really talks about how you can rise to your level of incompetence. And that can happen, I think, in any organization. It's something that we have to be aware of, but it can happen in the military. And so, when they call people military leaders, and I'm not, saying anything negative, I've had some incredible mentors and leaders in the military, but, just staying around long enough doesn't make you a leader. Just like Dr. Cripps was saying, the importance of kind of learning with these positional changes, you have to learn how to lead. And so, the military also has a massive amount of opportunities, whether it's, overseas or in the States, but sometimes we really have to figure it out because old people don't stick around the military. Like, I really am a senior guy, and that's concerning that, we don't really have a lot of gray hairs because they get out because it's such a frustrating bureaucracy, which means that it's more important, I think, to have, leadership in the military. And then transience, the fact we move so much, every couple of years we move. And I think we can compare this to the civilian world. So on one hand, you have a chance to reinvent yourself. On the other hand, you really have a hard time figuring out roots. If you look at leaders in civilian institutions, they've been there usually a long time. I think when so for leadership for civilians, promotion is not an assumption. You have to work hard to get promoted, whether it's through professorship or within a department. It's not something that's assumed. It's something that's really merit-based. And I wish that in some ways the military had more of that. I think mentorship in the civilian world, and I've had a huge opportunities and fortune to do a fair bit of training in the civilian world. And I think mentorship to really guide you through the promotion process and the leadership and bureaucracy of the civilian hospitals, mentorship is necessary. And you have to really choose, do you want to be academic? Do you want to be clinical? And Caitlin touched on this, or do you want to be educational? And there are opportunities to rise through leadership in each of those. If it's academic, through getting funding, getting grants, publications. I mean, a clinical career path and leading clinically, I had an opportunity to do that at Launch School. I was the chief of surgery there for a few years, and I loved that. And I should probably talk a little bit about my path, and maybe I'll pause and do that for a second. I actually have tried to push away a lot of leadership because I never thought I was ready. I mean, I don't know if that's imposter syndrome or fear of failing, which are probably overlapping in a way. And I always wanted to do a good job for the people that I was, leading, or the people that I was a boss of. And so, but clinical leadership as a department chair, and I was quite young when I was doing that, that's one of the things that's a risk and benefit of the military. But the best thing about it is I got to look out for my colleagues. I got to take the hits and my colleagues got to do stuff. And I loved that. And it was one of the things that I realized that I kind of like the idea of leading, because you get to take care of people and you get to facilitate people doing their job. And if that's not something you want to do, if you don't want to facilitate other people doing academics, other people leading, other people doing education, then you're probably not meant for leadership. And then another thing in the civilian world, while permanence can be an advantage for leadership, it can also be a challenge. If you have a problem somewhere, you have a hard time shaking that. Whereas in the military, there's a good chance you're going to move. I want to talk briefly about saying yes and saying no, because I think that as you move in and as you're considering leadership positions, what do you say yes and what do you say no to? You say yes, you don't want to miss an opportunity. So you keep saying yes, but sometimes you don't always know what the right opportunity is. And I think that really thoughtful decision-making, not saying yes to everything just because it's something on your CV, but being strategic and thoughtful about it. To me, it's really easier when it's not about you. If you're saying yes for something because it's going to help a cause, help a mission, be something that's going to improve the service, improve the hospital, improve patient care, to me, it's a lot easier to say yes. When you have focus on it. And I've said no to I've gotten some offers for some jobs that people thought I was crazy for saying no for. Oh, this is going to help your academic career. Oh, you're going to have such a better job getting out when you get out, if you have this leadership position, but it wasn't right for me. And so I think you don't want to say no because you want to shy away from work. You have to really look at yourself and understand the why. So I said, don't shy away from work, or I said that, but then the balance with that is she that does everything accomplishes nothing. And so you have to be thoughtful about, what you're choosing to do, because you want to succeed. Doing 1,000 things 1 inch at a time instead of one thing 1,000 inches, that balance is hard. And I think we all see the more we do, the more we end up doing, right? So there's this snowball effect. So really trying to balance that. Dr. Cripps mentioned the books. Those are great. I also recommend Team of Teams and this book, Start With Why. And if you don't want to read the book, watch the TED Talk. It's all about your purpose, understanding your purpose. So you're either you're going to be driven towards leadership, or you're going to be put in leadership. And knowing what your purpose is going to make it a lot easier and make it much more joyful. Otherwise, I think people burn out because they're put in positions that they don't really want to do and that they feel obligated to do. So how do you know if you're ready for a senior leadership position? It's not just about being senior. I mean, I love this if I had to show it twice, because this one's pretty awesome. So it's not just about being senior. It's not about being the old guy. It's really about trying to do the right thing. And also for me, a lot of people kept pushing me. I think about people over the last, 8 years, 10 years of my career that were really pushing me and encouraging me to take leadership positions. I was probably a little bit slow to do that, but I recognize that. And you've got to be willing to go to battle. You've got to be willing to talk to people and to be confrontational if you have to be, to support the mission and support your colleagues. And to me, that's something that's actually quite rewarding. If you can't communicate well, and if you can't be compassionate, because people will mess up, people will disappoint you, you'll disappoint yourself. You have to show yourself compassion too. And you have to be able to confront your colleagues, your bosses, your peers. You have to be able to do that. If you can't do that, you're not ready. So from military, you got to also color outside the lines. I know Joshua Dilday's on there. You just got to color outside the lines to affect change, even though that's probably something they probably say in every military leadership class, never color outside the lines. But if you want to change things, you've got to be willing to color outside the lines, and you've got to take risk, not for yourself, for your people. Like if someone's doing the right thing, but they're going to take some heat for it, take the heat for them. I think that that's something that's really important. A culture of compassion. If you don't have compassion for other people, you're not ready to be a leader. You've got to be stern, but we're all messy. We all make mistakes, and give people a chance to learn from that. I think you have to be brave and do what's right, even when what's right is difficult, and it usually is difficult. You're not afraid to communicate. We talked about that. You believe in team building. No one leads alone. Build a team. And the first 90 days talks about that. Stanley McChrystal's book, Team of Teams, which is an incredible book, talks about building the right team. Obstacles should be seen as a challenge. And Cripps talked about obstacle is the way. If you're in it to make it better for the mission and better for your partners, better for your patients, you got to be receptive to feedback. Those 360 evals, they're crucial. And sometimes they're hard to read, but it's all about getting better. And if you're not willing to constantly get better, and if you don't feel that this is your purpose, then it's probably not right. So lastly, I'll just conclude with, when you look at this picture and you think, who's the leader in this picture? If you think that this is the leader, then I'd say you're probably not ready for a leadership position. This is actually the leader, the one that you can't see, the one that, isn't getting the credit, that isn't necessarily out in front, but is facilitating other people to move ahead. So thanks. I really appreciate the opportunity. This was a hard talk for me to put together. I really had to think about it. And so thank you for the opportunity to think about these challenging things. And I'm looking forward to the discussion.
Thank you so much, Dr. Gurney. Another fantastic talk, and you're very right. You know, as a leader, you're only as good as the people that you surround yourself with and your team. So thank you again. Last but certainly not least, we have Dr. Kim Davis, who's a professor of acute care surgery and division chief at Yale University, and she will be giving our final talk on when is it enough, navigating scaling back and retirement. Thank you, Dr. Davis.
Thanks, Lisa, and thanks, Ryan. Jen, I have to tell you, that's one of the best talks I've heard on leadership, so you are to be applauded. I'd kind of like to echo some of the things that you've said. It's mentorship, it's sponsorship, and it's 999% about your people and doing the right thing. And sometimes that's hard, and sometimes it's easy. I've been fortunate. I have a group of individuals that are absolutely phenomenal, but totally agree with everything that you said. So thank you so very much. And I've read a number of the books you suggest. They're great. So I have no disclosures other than I enter my 6th decade at the end of the week. And I actually never really thought I'd make it to 60. Actually, I guess I'm entering my 7th decade. I don't know. Anyway, I never really thought I'd make it to 60, and I certainly never thought I'd make it to 60 at an institution where I have now been for 18 years. So I have some perspective on how it is to get ready to retire, although I have not yet retired, obviously. And just some thoughts about how to be ready to do this and what to think about. And this is particularly important for the young members on the Zoom call, right? It's a Zoom webinar. I am old. But this is particularly important for the young people because it's all about how to prepare yourself so that when you hit an age where you don't want to work anymore, or you have a problem where you can't work anymore, you have the financial resources to walk away and maintain the quality of your life. So some data about surgeon retirement, and this is not trauma surgeon retirement because so many of our trauma surgeons stay around forever. But the average retirement rate for surgeons is 64 and dropping. And the reason that it is dropping is that people are unhappy with the new surgical environment. But the average age right now is 64. Interestingly enough, there are no guidelines or requirements or mandates about who should retire. There are no age limits. There are people that are practicing surgery in their 80s. Who probably should be. There are people that are practicing surgery in their 80s who probably should have stopped in their 60s. So age is not a number, but it's more about how you are able to function, whether you are able to function, and how easily you can take care of your patients. So when you start to think about slowing down, you have to think about your stamina. I know that I can no longer take night call. For a number of reasons, not the least of which was it took me 5 days to recover from every night that I spent in the hospital for a 24-hour call. And it gets harder decade after decade. Many of us, particularly as we get older, may have issues with cognition. And what's worrisome about the issues with cognition is we may not realize that we're having issues with cognition. So as you look towards your senior years as a surgeon, it's really important to take cues from the people around you who are telling you that your memory is shot or who are telling you that your hands aren't working as well as they used to. None of my faculty are saying that, thank God, although I know my memory is shot. So you have to take clues from the surrounding environment. You have to ask for feedback. And again, this is a time when a 360 may be helpful. And then it's well known that as we age, due to a number of reasons, everybody's fine motor skills decline. So that is something else that you need to take into account. I think reasons to consider retirement, the best reason to consider retirement is you want to retire, right? You've worked a good career. It's been awesome. It's time to step back and let somebody else take over. But more often than not, it's other issues. It's underlying comorbidities, it's diabetes, it's hypertension, it's whatever you can think of. Arthritis is a big one. With all the laparoscopy that we're doing, it can be ergonomic issues, particularly cervical stenosis. The number of your friends who will have their necks operated on in the next 10 years is astonishing because of the completely abnormal positions that we put ourselves in for laparoscopy. Our eyesight declines as we get older, and you can develop a neurologic disorder. And then finally, I kind of touched on it, but cognitive impairment as you age is a fact of life. It's a question of whether you have rapid cognitive impairment or slower cognitive impairment, and there are things that you can do to minimize it. But you need to listen to the people around you. If they tell you that you're not making good decisions, you need to listen to that. So who has stakeholders in this discussion? Well, first and foremost, it's the patients, right? You don't want to cause harm to patients because you shouldn't be operating anymore. And oftentimes in some of these surgeons with extremes of age who are asked, translate, forced to retire, it's because of a series of untoward patient outcomes. You do not want to be that doctor. So you need to keep track of how you're doing, if your patients are doing well, et cetera, and so forth. Your colleagues are stakeholders in this discussion. They may not want you to leave because they love the fact that you're there to help them. You're the doc that answers the phone in the middle of the night, can answer any question about any problem, and is more than willing to come in and help. Even Caitlin for that little, just pop in and make sure I'm not cutting the common duct. It's the cystic duct. That view looks okay. I can't tell you the number of times I get that phone call because it's not just a gallbladder. We all know what an acute care surgery gallbladder looks like. I'm going to discount a little bit the payers and the hospital administrators because I think that they are less important in this discussion unless you are the doctor that is frequently being sued for untoward outcomes, et cetera. But it's really society that benefits from our ability to determine whether or not it's time to step down. There are assessments of cognition. Yale actually implemented a policy just like Stanford, probably 7 or 8 years ago, and then we got dragged into state court, and then we had to roll it back because several of the physicians, not surgeons fortunately, but several of the physicians who were over the age of 75 who were forced to take mandatory cognitive and health screening evaluations sued the hospital because they said it was ageism and unfair. But Stanford has a forward-thinking policy requiring physical assessment, cognitive screening, and peer assessment of clinical performance for all physicians over the age of 75. So I think it's important as we age to have ongoing medical evaluation and make sure that any underlying disease is treated. And if there is any concern that you can't remember what you're doing, or you can't find your keys, any one of a number of issues, then requesting and going through cognitive testing is a good idea. There are two types of people who retire. They're the people that retire and just walk away. I don't think that really represents most of the surgeons. So for surgeons who want to stay engaged, you can assist in the operating room. You can provide mentorship and sponsorship and really come in and say, well, you're struggling here, let me help you, but you do the operation. A number of our older surgeons have transitioned into an office-based practice where they only do low-risk procedures. A huge benefit to our training programs is to have the older surgeons staff resident-based clinics or round on hospitalized patients who are on the ward that then free up the younger surgeons to actually go into the operating room and fight the good fight. And then, of course, you can never say enough about teaching and mentoring. So, they talk about the hobbies that you can do when you retire: game night, watch good television. Good luck if you can find it. Do brain exercises. Personally, I love doing crossword puzzles. Get moving, but there's only so much that you can do to get moving because there are only so many hours of the day and we're old. Play an instrument, work with your hands, learn how to cook, write and reflect. Surgeons are really good at that. Dance, bake, grow your garden, or pick up a paintbrush. But I think Krista Kaups put it best in an article in the ACS Bulletin. For most surgeons, it is unrealistic to anticipate personal fulfillment in an abrupt transition from a busy surgical practice to working out a few days a week or a few hours a week. So you have to find something that you enjoy doing, and you have to start. I personally believe that you should transition gradually. So I just want to highlight some portions of this slide. It wasn't necessarily designed for my talk, but it was published in JAMA Surgery in April of 2020. And I want to highlight some of the things that are relevant to this discussion. Many retired surgeons who retired abruptly wish that they had postponed retirement by gradually slowing down. Many wish that they had been more involved in teaching and mentoring. Many wish that they had embraced a new surgical technology like robotics that can extend the life of a surgeon who may be having arthritis, more volunteer work, and being humbler and more collegial. So the top 10 mistakes are ones that you start when you are a junior faculty member. And the first is not to have a plan in place and not saving money now. If you are not maximizing the 401 or 403B retirement programs in your institution, you need to. Not only that, I think you need to have somebody, we all say that we're smart enough to figure out how we're going to invest, but we're not investors, right? This is not what we do for a living. So you wouldn't ask your secretary to take out your appendix. I give all of my financial workings to a personal financial specialist, and I would encourage you to do that. Make sure that you take advantage of any employer matching. And you have to think about the tax implications, right? So for anybody who's making more than $500,000 a year, you're paying about 42% of your income in taxes. If you can bring your income down and cut your tax bracket before you retire, the first year that you retire, or it's either the first year or the first 3 years, you're at the tax bracket that you retired at. So it's really important to bring your earnings down before you actually retire. You should always let your retirement savings accumulate, and this goes for Social Security, number 9, not being strategic about Social Security. You can pull Social Security as early as 62, but if you let it accumulate, you get more money in the long run. Life is uncertain, so if you don't plan for your health and for long-term care, you are probably selling yourself short. Those of you who do not necessarily have a built-in support network, having long-term care insurance so you can stay in your house and afford somebody to take care of you is extremely important. And to remember to plan for your estate. So how much do you need to retire? A good rule of thumb is 70 to 80% of your current income. I will translate that for you. If you are earning $500,000 a year and want to retire at 65, you're probably going to live 20 to 25 years. You need $8 million in the bucket. You don't necessarily need all of that $8 million when you retire, but you need to have that money invested carefully so that it continues to grow, so that you have the amount of money that you need to live on. Again, some of this will accrue as your investments grow over time, and you can always estimate that your investments are going to grow at about 5 to 7% per year if you're well invested. Other calculators suggest 12 times your annual income, which is $6 million if you make $500,000 a year. If you make more, you need to put more aside, or you need to change your quality of life or your style of living. I strongly encourage everybody who has an MD after their name who is drawing a salary to consider a long-term relationship with a good financial planner. Maximize your retirement dollars through maximal donation and employee matching, and pay yourself first. I know a lot of you want to buy a nice car, but the nice car is only going to last 7 to 10 years. It's much more important to put your money in the bank and get the nice car a little bit later in life. So my biases, and everybody who knows me knows that I have an extraordinary number of them. Phased retirement is probably better than abrupt retirement. It allows for ongoing engagement and your brain continues to work. If you can bring your income down, it allows for some tax benefits, and it allows you to slow down and find things that you like to do outside of work before you abruptly transition. It is extremely important to have not term, but whole life insurance, disability insurance, if you can get it, separate and distinct from what's offered at your institution. Health insurance is obviously offered by all of our institutions, but please consider long-term care insurance. It is a very worthwhile investment. And though age is just a number, we as a group may not be aware of our functional decline. So ask for feedback, talk to your peers, and don't just write off that memory loss or those aches and pains. It may be a sign of a real problem, and you may need to accelerate your retirement. And finally, although most of my colleagues, when I talk about this, say, oh, you don't want to retire, you want to work forever, including my boss, who said we're not going to talk about fiscal year 28, which is when I plan to retire, or at least slow down. Retirement is not a sign of weakness. It is a good decision to extend the quality of your life. So we're so busy watching out for what's just ahead of us that we don't take time to enjoy where we are. Thank you so very, very much for the opportunity to speak, and happy to answer any questions.
Thank you so much, Dr. Davis. That was a fantastic talk and something for each of us there, not only in later phases of our career, but things to think about in early and mid-career as well. So we're already at the Q&A part of this session, and I do see one hand up in the chat, Dr. Brady. I'm not sure if that was a question that you had, and Ryan and I have some questions as well, if there are no further ones for the audience.
Yeah, I think we just encourage people to write their questions in the chat box. I have a question, and it's really geared towards, I guess, Drs. Cripps, Gurney, and Davis, maybe a little bit more, and Caitlin and Dr. Fitzgerald, certainly welcome your thoughts too. But Dr. Gurney, something you said really kind of resonated with me, and that's the importance of exercising your confrontational muscle, so to speak. And I guess my question to you is how do you exercise that, and how, because that's really very challenging, and how have you guys as leaders found a balance between really doing that for the mission, as you kind of explained, but also, you know, remaining obviously professional and those kinds of things? I thought that was particularly interesting.
Yeah, well, nobody likes it. If you like confrontation, that's maybe you need to read another book. I'm not sure which one it is, but nobody likes confrontation, but you have to do it. And like anything that we do, practice makes you better. So, and having a coach at something or starting small, I mean, maybe it's just how you talk to residents when they don't meet your expectations. One of the things that I've done when I've had to have some challenging conversations with people is I'll have someone else in the room. And for one reason, it's because sometimes when you're telling somebody something, they're not always hearing you, and you don't always know how effective you are. So then also asking for feedback for how you did, when you're having the difficult conversations. But you have to do it. I mean, it doesn't mean you like it. You just have to do it. I mean, the confrontation I don't mind is when I'm advocating for something, advocating for a patient, advocating for one of my colleagues, like that's easy. But telling someone that they've disappointed you or that they haven't met your expectations, and and it goes both ways. People are going to tell you the same thing too. I mean, you want to get that feedback from people, so you want people to be able to have the difficult conversations with you on the receiving end. But I think with anything, it comes with time, and you can learn to get better at it. And if you love confrontation, then that's a problem in itself, but it's something that you have to do. I mean, you have to be able to have those difficult conversations. I'd be curious to know what the other panelists think about that.
Yeah, going along with books, Harvard Business Review's book, Difficult Conversations, is probably a must read for that very topic right there. And the Extreme Ownership series by Jocko Willink and the Navy SEALs, they will discuss frequently that difficult conversations had now pay much more dividends than holding it and waiting it for it to become a disaster later on. So you may think it's difficult now, but it's much, much easier than waiting for this thing to develop into a full-blown disaster.
And it doesn't
I
always
wouldn't
have
call it conversation as difficult, not confrontation, but difficult conversation.
Yeah, it doesn't always have to be confrontational. I mean, you can always say, I understand that you're looking at this through this lens, but let me reframe the view for you and tell you how I'm looking at it, so that perhaps we can find a way to get together in the middle. Because I will tell you that having confrontational conversations, particularly if you're female in a room full of men, can be a problem. So finding a way to tactfully get them around to your way of thinking is more effective than any confrontation.
Yeah, I agree with that. I mean, maybe maybe confrontation wasn't the right word for it, but having the difficult conversations, and sometimes it depends on how people react to it. But the other thing is, I think that just like anything, before you do, I mean, I know a lot of us don't do a ton of elective difficult cases. We might do some of them. They're usually our hard cases or the trauma ones, but just like with some elective cases, you war game it out beforehand, you think about it beforehand. I think the same thing with some of these conversations, think about how you're going to do it. Don't just go into it without really kind of a thoughtful plan about how you're going to have the challenging conversation.
And never go in when you're pissed off.
Yeah.
Always
I think we probably
take that
all learned that the
24
hard way.
Always take that 24 to 48 hours to
That's
reset,
great advice.
regroup,
Yeah.
and have a
It-
nice, calm conversation. It's like that email that you should never send.
Right. A direct approach is rarely actually the best option. As surgeons, we tend to think like, I'm going to tell you exactly what I think you need to know right now. That is typically not the best approach. The direct approach is not, it's an indirect approach. It's what Dr. Davis says. Anytime, be thoughtful, don't go into it emotionally constrained.
Those are great answers. I have one question, and there's one question in the chat. My question was about non-traditional pathways of leadership. So I think we do a great job, and there's a lot of discussion around, the kind of classic progression to section or division chief, chair. What about cultivating leadership opportunities, in perhaps less traditional pathways for surgeons? How can you take advantage of that? And then there's a question from the chat about how you go about balancing your own self-discovery with then making an effort to fit into your own chosen institution.
I mean, I can start with some of the non-traditional leadership, and I'm sure that other people have comments on it, but there are people that go into certain things thinking this is what I'm going to do, and they have a plan and they have a roadmap and they've figured it all out. And that is definitely one way. I think some non-traditional leadership opportunities, they're opportunities that they show, that's like the game of whack-a-mole. They show, and then you've got to grab it really quickly. So, I mean, that's the thing that's hard, is knowing what to chase down and what not for, when you say non-traditional, whether it's, international opportunities, some educational pathways. But, recognizing that, and mentorship, I think, is really important for some of those. If you're interested in something that's non-traditional and you see somebody that's doing it, ask them, figure out how they were, what their success and failures were, learn from their experience.
Yeah, I joke a lot of times I kind of forced my way up to leadership. I had a different plan when I showed up. I was like, this is what I'm gonna do, this is how I'm gonna do it. And then that did, and then it turns out oh, okay, well, there's this other thing that I kind of enjoy a lot, and that's okay. And the important thing goes back to negotiating your dream job while you're at is a very, very doable thing, right? So, hey, this is what I was doing, and this gets to Dr. Nora's question in the chat, how do you self-discover? Have these open conversations with your leadership there. This is what I'm doing. This is my game plan. This is my goal. As you go through that, you will hit difficulties, and then have these conversations with your leadership. Is this a difficulty that's overcomable? Is this something I need to pivot and move? What sort of support do I need to get past that? And don't try to go through it by yourself. As I think probably Dr. Fitzgerald said, I said, Dr. Gurney, Dr. Davis, everybody said it. Don't try to do these things by yourself. There's people out there that have gone through it. Talk to them, ask them. It'll help you discover more things about yourself, and your pathway may not be what you thought it was when you showed up, and that's okay. Work to pivot, work to stay in alignment with your team and your institution, and you can be successful doing that too.
I think too that, a lot of things that we learn as leaders, we never learned in medical school, right? It's kind of like assuming that we're all going to be great surgical educators, but we never learned how to educate in medical school, although some of the younger people may have now. But you should avail yourself of available resources such as coaching. And you can have different types of coaches at different phases in your career, and should have different types of coaches in different phases of your career to kind of reflect and help you build, because this is a muscle that we need to build, we need to stretch, and we need to maintain. It's not a muscle that we are born with, and the whole surgical mentality is actually counterproductive to being an effective leader in a matrixed environment. Do it my way or the highway does not work in a matrixed environment.
Correct.
So
To
true.
add on to what Dr. Cripps said, I think, in speaking with the self-discovery within your institution, I think, one of the goals should be that wherever you do end up, or if you're making a transition, that the institution should be a place where you feel like you can allow for self-discovery. And that's why I think, as I think Dr. Cripps mentioned, it's really important to have conversations with, people in your department or your medical TMD or your division chief to let them know kind of what your expectations are, what you hope to get out of this phase of your career, or kind of looking forward to the next phase of your career, to make sure that your wants and needs are hopefully being met, so you do allow yourself that space to grow within your current job or future job.
Very true. I think those are all the questions in the chat, and I see we're at 3:01. So I want to thank all of our speakers once again. This was a fantastic grand rounds. We got lots of positive comments in the chat as well from attendees. So thank you all for your time, and look forward to the next grand rounds.